So thanks, Irini, and thanks, PK, for inviting me again. It's a pleasure to be here. We're going to talk about, do I need lithoplasty for complex iliac disease? And I think it's germane to the two cases we just saw. These are all my financial disclosures, for once not really germane to this talk. So why is this going to be a difficult topic, in my opinion, to describe? And the reason is that femoral access, as was just shown, in particular for a cardiologist, has become fewer and far between now. Most everything is going radial. So if you want to see fellows turn white, have them hold a large bore sheath closure that you forgot to pre-close. It's a real problematic thing. And so these femoral accesses remain critical for several cardiovascular procedures, whether it's high-risk PCI, EVARs, TVARs, and the growing market of TAVR. Unfortunately, iliac disease is very common. Iliac occlusive disease is really the rule, not the exception, particularly in long-standing tobacco and renal failure patients. We have created improved long-term patency with stenting based on the scientific data, and I'll try to show you some of that. However, the risks for perforation remain in complications due to diffuse calcification and the unforeseen risk of calcifications that you may not see fluoroscopically. So dilatation, which is really the problem here, and if you're old enough like me, I think Serini just called me old, and I'll take that as a positive. The problem with balloons today are that you're using semi-compliant balloons, and for those of us old enough to remember nonlinear expansion, you see differential expansion in your balloons, and that's when you get into trouble with ruptures and perforations. So I'm going to show you two cases. These are a couple cases that I've done. One is relatively old, it's dated, so it kind of goes with the MO of me being old. Both were treated with PTA and stent. One went well, the other didn't, and I want to see if you can notice the blush. This is the first case, a fairly complex aortoiliac reconstructive case, modest calcification, but not too bad. And following our stenting, we had a good angiographic result. This is, kind of 3 stents to recreate pants and suspenders. The second case has a fairly diffuse calcific bridge here. This is a young lady or moderately aged lady who was claudicant on the right limb. Now notice this area right here. This is after balloon and stent with an open cell design. And she didn't have a lot of pain with the balloon, but the minute we let the balloon down, she had a decline in her hemodynamics, and you had to really focus on this. And it's kind of this teardrop. Now, this is a very old slide, so what we had was a covered stent, which was called the wall stent. You still have it today, and we were able to seal that. But both cases look pretty much the same. It's just how they separated themselves was based on the dilatation. And again, I don't think we did anything terribly wrong with anything, but we had a complication. So the results of iliac angioplasty, this is the original iliac trials. The reason why it works, we were talking in the past couple cases, there was an old paper by a guy named Teteru years ago that said if you had a gradient, you can leave PTA alone. And then if you did have a gradient and it used 30 millimeters of peak-to-peak difference, they said bailout stenting was the answer. Things shifted at that time. That was the late 90s. And then you had the Dutch iliac trial and the wall stent trial, and you could see how stenting did very well. Did not only well short-term, but long-term. Here's the angiographic restenosis from the old Palmaz registries. So they did mention, I don't have time to go through the other trials of Discover and so forth, but this is the original COBEST trial. Mawapati did the presentation at Viva and subsequently presented. The real key was it was a randomized trial of about 120 patients, 167 limbs, and they looked at duplex and CTA outcomes at both 6 months, 12 months, and then out to 5 years. The difference, as I think Dan Clare suggested, was the difference was not A and B, but in the more complex lesions. Not calcific disease, but complex lesions, which lended itself to the need for covered stenting. And you can see here that the solid lines are symptomatic, how you felt. Doctor, I can walk better after you do an angioplasty. But you can see in the red line, which is the covered stent, this is the V12. This is ICAST atrium, so we don't have those, at least we didn't at the time, have the V12s here. But these can go up to 12, 14, and 18 millimeters. And then you can see the bare metal stent. Where the separation came was in that CD group with primary patency very good and secondary, the bare metal stent not so good, out to the time frame beyond the 12 months. So what about lithoplasty? It's a long background to kind of show you what lithoplasty is all about. Remember, lithoplasty is just an electrical discharge, which tends to give you this shock wave, this kind of forward wavelet of pressure that's in the shortest location. The more focal location is about 50 psi. And it tends to disrupt locally, but not disrupt deep. So it's about a 2 millimeter, at most 2 millimeters, about a millimeter or less disruption. And why is that important? Well, it tends to disrupt in situ calcium without disrupting the artery, which is kind of what you want to do as an interventionalist. Let's get off of that. So remember, they've done now 3 studies. The PAD 3 was their pivotal trial, which I'll show you in a second. This was PAD 2, which really kind of showed you the overall outcomes of acute gain. This was just a fact-finding mission. This shows you how old I am. I'm going to reading glasses. So the dissections were minimized because, again, it was an in situ thing. Perforations were 0. So again, as a fact-finding trial, it showed that the device worked. It got in, it got out. The FDA cares about 3 things. Can you get in there? Can you get out of there? Does it do its job? It did all 3 very well. So for shockwave, they're keenly aware, again, for cardiologists who live through brachytherapy, for geographic miss. The peripheral iliac, or the peripheral the catheter, is 6 centimeters. It has 5 emitters, 2 on either side that work in tandem, and a center emitter that works on its own. And so if you had a lesion of 7 centimeters and you just went 6 and pulled back a little bit, you may have a geographic miss on either the front end or the back end of that lesion. And they were very keen to make sure you covered that. When you cover that, if you have to go longer, you have to make sure you cover the entire lesion length with either DCB or stenting or whatever you want to do. All right, let's get to the data of lithoplasty. This is the PAD 3. Again, Gunnar was the lead author of this. Bill was the senior author. And what they looked at was out to 6 and 24 months, 306 patients randomized to intravascular lithoplasty plus DCB in an SFA trial compared with DCB alone. Lesion length was very respectable, 10 centimeters. The lesion length as tested was about a 15 centimeter lesion length. Calcium, 129 millimeters versus 125 millimeters in both groups. And the PACs were severe scores in about 83%. And let me go back there. So you can see that the primary patency overall did very well for the lithoplasty. Again, vessel prep, as we know, the impediment to getting drug to the artery in the SFA is improved by cracking that calcium and allowing drug to reside there. The primary patencies, well, I won't go through it. The primary patencies at 2 years, there's always going to be a decline, 70% versus 50%. So again, that coin flip for PTA is kind of where most other trials have been, both statistically significant. So these are slides, actually, I asked the company for what they have. And so this is the iliac stuff that in the 2 minutes I have, I want to show you. Why do this? Well, by doing lithoplasty or atherectomy or anything that we do for vessel prep, what you're going to show is less balloon pressure to dilate the artery. And that's good, right? You have less vessel trauma. This is all self-reported data. This is part of their observational study, which you'll see is an OS. So it doesn't mean it's scientific, but what you cannot lie about is how much pressure it took to dilate the artery, and that's what this is showing. So this is like atherectomy from CSI, their orbital 360 data, which was purely non-scientific, but the data was I can dilate the artery earlier with less pressure. So that's what this is trying to show you. This really does allow the safe access, again, for severe calcification. This is an observational study for large bore closures as well as for claudicants. 17 patients were in the large bore closure. This was the kind of entryway for iliac passage of a sheath for TAVR, for example. That's what this is trying to show you. And it worked very nicely without complications. This is from their observational study. I think this is Shishibor's publication. This is all just registry data from 2017 to 2021, 30 sites, 1,300 patients, 1,600 lesions, and they looked at the IVL treatment. It ran the gambit, iliac, femoral, common femoral, et cetera. If you looked at the iliac group, it was about 16% of the patients were actually studied. The milieu between iliac and non-iliac was the same. The Rutherford 3, 4, 5, whatever, it was pretty much a wash when it came to the iliac group. But the iliac PAD subgroup, again, 242, did very well for both lesion lengths, again, about a 6 centimeter, that's about right for the common iliacs. And what about their outcomes? So their outcome actually did pretty well. Understand that their predilation, and I was going back to the why use a device if you have to predilate it. This is not so bad when it comes to iliacs, but it can be kind of concerning when it comes to the coronary because a small amount of dilatation probably can get away with dilatation. So Here is probably just to be able to allow entrance and then crack in situ. So I don't think that's a bad thing. But if you look at adjunctive therapy, 3% still got atherectomy, but most of it was just specialty balloon. And then they did DCB and stenting, is what you would expect. Their final outcomes on diameter stenosis for the iliacs are actually quite good. Their overall safety profile is also quite good. So when you summarize this, do you need it in every case? I think the answer is no, but you have to pick and choose where you are. And the downside to not picking it may be a major complication. So iliac disease does play a role in our interventions for all the things that we talk about. Simple PTA and stent may not be the best option at the time of the index. The risk of PT alone may not allow passage of the large bore devices that you have, but IVL appears to be an attractive alternative for access for these procedures, and it still requires attention to detail. It's not a panacea, and the risks are not entirely mitigated with IVL. Predilatation is still necessary to deliver the device, which may suggest higher risk patients, and facilitated delivery is essential for successful procedures, particularly for those of us who do TAVRs. And it still allows for stenting post-procedure as needed for clinically indicated patients. So I went over in a minute. I apologize. Thank you for your time.